Clinical Care Classification System version 2.5, which I will call CCC. As a developer of the CCC with colleagues at Georgetown University, I am presenting this second video entitled 6 Steps to Develop a Nursing Plan of Care Using the CCC System. Before we begin, I want to provide a brief overview of the CCC as described in detail in the first video. The CCC was approved as the first national nursing standard by the Secretary of HHS. The CCC supports the electronic capture of discrete, coded patient care data for documenting the essence of care, and which can best be accomplished with the development of an electronic nursing plan of care, or POC, using the CCC. To review, the CCC consists of a 4-level framework which allows data to be aggregated upward as well as parsed downward to atomic level data elements. The first level consists of the 4 healthcare patterns. The second level consists of 21 care components which are used to classify the nursing terminologies. As you can see, each of the 21 care components is categorized as the healthcare pattern. The third and fourth levels consist of the nursing terminologies. The CCC of 176 nursing diagnoses, 804 nursing intervention actions, and 528 nursing outcomes. Together, they form a single interrelated system. The CCC is also used to document the 6 steps of the nursing process required by the ANA for professional nursing practice. The CCC can also be illustrated by the information model, whereby the terminologies not only link to each other, but also are interactive, allowing for feedback, making it possible to review, revise, and update the care process at different points in time. It is also an interface terminology and is interoperable. As a result, it is mapped to SNOMED CT for the electronic transfer between EHRs as required by HHS for meaningful use. Now that we have reviewed the framework, I want to point out that the current paper plans of care are impossible to retrieve and or analyze. But in an EHR plan of care with the CCC terminology, you can provide a standardized plan that can be used not only for documentation, but also for analysis of clinical nursing practice. Such a system requires at least 3 features: hardware, software, and nursing content that you should be aware of. The hardware architecture needs to be designed to store the data elements and codes in its data dictionary. It needs to be able to process and track the data elements by linking the 6 nursing processes together, and the hardware also needs to address HHS meaningful use and continuity of care requirements. Second, it requires software designed for documenting the plan of care with user-friendly input screens, drop-down menus, clinical pathways, and flow sheets. Remember, the user-friendly input screens do not need to display the CCC codes, which can be hidden and stored in the background. Also, keep in mind that the screens should be designed primarily for the expert professional nurse with minimal support for the student or novice. Remember, the POC is not a teaching tool, but a tool for the electronic documentation of the essence of care. And finally, the POC needs nursing content designed for the specific patient's clinical condition consisting of evidence-based information. And it should also be able to process and generate output reports and data on the patient's clinical condition that are usable for analysis, reuse, and aggregation for data warehousing. Further, the nursing plan of care data should also address the meaningful use CPOE requirements. It should integrate the nursing and medical orders into one unified plan, as well as address the quality indicators for the specific patient's condition. Now let me turn to my example for my plan of care for Mr. Jones. He is a 69-year-old male who was admitted to a hospital from the ER with shortness of breath when walking more than 20 feet, acute rib pain when coughing, and temperature of 102 degrees. A chest X-ray was taken in the ER which showed bilateral lower left lobe and right lobe infiltrates. The physician diagnosed the patient as having bacterial pneumonia and ordered oxygen therapy 10 liters, Demerol 50 milligrams IM, PRN for pain, breathing exercises Q4 hours, and penicillin 500 milligrams PO Q6 hours. On admission to the nursing unit, the admitting nurse initiates step 1 of the PUC by assessing the signs and symptoms of the patient's clinical condition and, as previously stated, shortness of breath, pain when coughing, and temperature, from which the nurse initiates step 2 by identifying the 3 nursing diagnoses based on the patient's signs and symptoms for pneumonia as breathing pattern impairment, acute pain, and hyperthermia. For step 3, the nurse needs to identify one of 3 outcomes or goals for the providers of care to improve, stabilize, or deteriorate. In Mr. Jones's case, the goal is to improve the 3 nursing diagnoses. In step 4, the nurse lists the plan and implementation steps of the POC. It should include the CCC nursing interventions and actions for each nursing diagnosis, using nursing jargon or common English phrases to help the nurse understand them. For example, for the breathing pattern impairment diagnosis, the nurse ordered 3 nursing intervention actions as perform oxygen therapy, with the nursing jargon as give 10 liters oxygen continuously, and for teach breathing exercises, the nursing jargon was instruct breathing techniques every 4 hours. To continue, for the acute pain diagnosis, the nurse only ordered 1 nursing intervention action as perform acute pain control, with the nursing jargon give Demerol 50 milligrams for pain on coughing as needed. And for the hyperthermia diagnosis, the nurse ordered 2 intervention actions, perform temperature Q6 hours, with the nursing jargon take temp every 6 hours, and perform medication treatment, with the nursing jargon give penicillin 500 milligrams by mouth every 6 hours. Remember, the intervention actions should be recorded at the point of care using a flow sheet with dates and times as the nurse administers them. This ensures that the POC can be used to provide a status report at any given time. The next step 5 is designed to review and revise the plan by day or by shift in order to determine whether any intervention action has changed and, if so, needs to be evaluated. For acute pain diagnosis, it was improved on day 3 and resolved because the patient did not have pain when coughing, and Demerol was discontinued. However, it was determined that the other two nursing diagnoses, breathing pattern impairment and hypothermia, were not discontinued and were still ongoing for the remainder of the inpatient stay. The last and final step 6 occurs on the day of discharge, that is, when all the active diagnoses must be evaluated and actual outcomes recorded. Thus, for breathing pattern impairment diagnosis, it was improved because the oxygen therapy was discontinued and the patient was able to breathe normally. And for hypothermia, it was improved because the temperature was normal and penicillin was discontinued. Once the plan is closed and the analysis of the POC, outcome information should be performed to measure the outcomes and analyze the nursing care. To determine the evidence-based practice, it can be based on the number and frequency of nursing intervention actions for each nursing diagnosis provided during the inpatient stay. For care measures, they are based on the comparison of the 3 actual outcomes to the 3 expected outcomes for the 3 nursing diagnoses. To continue with the analysis for workload and resources, they can be determined by a summary of the action types for the clinical condition for the patient or the nurse, and finally, for costs of nursing care, it can be determined by the number and frequency of action types based on predetermined relative value units. The POC on discharge should also address meaningful use CPOE requirements, include the quality care indicators, as well as discharge instructions. The discharge instructions for the patient should include a summary of the POC's nursing processes, instructions for post-hospitalization care, including referrals for continuity of care. The discharge instructions should also include a list of the reconciled medical and nursing diagnoses, as well as a list of the reconciled medical medications. The chart should be prepared for interoperability and referral for the continuity of care. The value of nursing POC, including the CCC, are remember it is used to standardize the documentation of patient care. In summary, the CCC is the national standard. It supports the capture of discrete patient care data. Note that the second edition of the manual is now available, and it can be ordered from the website. This ends the second video entitled 6 Steps for Developing a Nursing Plan of Care. Good day.